Thank you all for joining us today. And you all know that innovation in imaging modality and advancements of imaging technology have improved our ability to diagnose, monitor, or treat medical conditions. And recently, automatic registration, segmentation, visualization, classification, and also quantification of biomarkers have transformed the way we utilize medical images. And we have three fantastic speakers with us here today, and they will discuss some of the recent current technologies and also software development in this exciting area. So first, we're going to have Dr. Marc Modat. Dr. Modat is a senior lecturer in the School of Biomedical Engineering and Imaging Sciences at King's College London. He's an expert. He's an expert in medical image registration. Which was the focus of his PhD at the University College London. Over the years, he has gained significant expertise in computational imaging, including imaging processing, modeling, and machine learning. His research interests include, among others, the development of novel imaging-derived biomarkers for diagnosis and prognosis. He's involved in the development of many open source projects and in healthcare setting, including MONAI. I hope I have pronounced that correct. It's MONAI. It's a software package for medical AI, and he leads component of the London AI Center for value-based healthcare platform system. He also involved in the development of algorithm tools for surgical planning and also surgical guidance. Marc is also the leading expert that set up and developed the large-scale data analytical platform, which encompasses secure data transfer, storage, and also automatic processing. And today, Marc is going to talk a little bit about different projects that he has involved after some brief introduction of the field of medical image processing. So here, floor is yours, Marc.
Thank you. Thanks for the kind introduction. And I hope everyone can hear me well. Yeah, we should be fine, but just online. And thanks for having the three of us for this event and organizing it. So as just mentioned, during the 45 minutes that we've got together or so, I will have a three-part presentation. So first, I will introduce, let's say, the bread and butter techniques that we use in medical image registration. I will try to stay far away from equations and give you example of use case where we could benefit from medical image processing. Then I will present as well some example of how the field has been leveraging all of the opportunities that we could gain from machine learning, especially deep learning in these latest years, as well as some of the challenges. And lastly, I want to introduce some of the work that is done within the London AI Center for Value-Based Healthcare, where our aim, as I will explain a bit later, is really to make sure that we can take an algorithm from an individual laptop, or actually supercomputer, and put it straight within a clinical environment so that it can be used to impact directly on patients. So starting with the beginning, when we are dealing with medical imaging, we are dealing with large varieties of data type. We've got many modalities. You could see some of them on your screen at the moment. And I will expand on it, but they've got different dimensions, they've got many resolutions, there is quite a large amount of variability. On the top row, you could see, for example, three different acquisitions from the same body parts. So on the left-hand side, we've got an X-ray, which is basically showing us the density of the tissues, and it's a projection, it's a 2D image that we have to process here. In the middle, we can see volumetric CT scans that give us good insight as well about the density of the tissue, and we can have good visualization of the bones, but not so much of the soft tissues. And on the right hand side, we've got volumetric MR. Well, I'm only showing you one slide here, but where we don't have a so good definition of the bony tissue, but on the opposite, we can really well see the soft tissues. And at the bottom, we've got another variety of images that we are dealing with. On the left, we've got a video stream, or it's just a static one at the moment, that we could get from endoscopic imaging. Same thing on the next to it. The second one from the left at the bottom, where we can see that we've got a tool during surgery and we want to be able to monitor these tools. Then the colorful images in the middle is showing us the amount of radioactivity uptake that is binding to a specific molecule in someone's brain, and we can quantify and analyze this information. And we've got ultrasound imaging as well on the right-hand side, where we've got 2D plus time, where you can see actually the probe figuring, and we can reconstruct the baby, and we've got 3D ultrasounds highlighted by this rendering. So, and that's only a snapshot. I'm sure you will see more today. But it just basically, when we deal with medical imaging, we have to process a large amount of modalities. And we do it for multiple purposes. I mean, one of the first things that we tend to do when we process images is try to make our images nicer, stronger, faster. So removing artifacts that could be coming either from the acquisition device or for the subject being imaged. And there you can just see 3 examples where on the top we've got artifact correction. So we've got motion artifact on these cardiac images, and by considering the physics of the MR acquisition, we are able to identify the corrupted slices, remove them so that we can have a better reconstruction. And I hope you can also see with me that the image on the right-hand side, we've got a better delineation of the chamber we want to image compared to the left-hand side. At the bottom, you can see same thing, an extract from a CT image where we are focusing on the abdomen, and we are able to run classical denoising algorithm so that we improve the contrast and remove the noise. And on the right-hand side, we are also doing that on longitudinal imaging, on temporal imaging. That's a big heart, where leveraging on the fact that we've got information over time, we are able to condense all of this information and correct for to correct and improve the contrast. So that's one use of image processing. And then we also use image processing a lot to extract biometric information from images so that we can present them to clinicians, especially radiologists and neuroradiologists in the case of these brain images. And this is simply an example. This is work by Carol Sud. So she was able to take the images that were on the left-hand side, and then from this MRI scan of the brain, she was able to detect lesions within the brain, so abnormalities that she could automatically detect. And then she was able to have a graphical representation on the right-hand side, which is this bull-size view, which easily enabled a clinician to have an overall view of the brain without having to spend a lot of time flicking through the different slices. And it's really trying to extract this information to improve or to create metadata and derive data that can be useful for the clinical application. Another example of the way we are using image processing is to monitor longitudinal changes over time. So what you can see on the left-hand side are 2 scans of the brain from a single individual. So that's the difference between the scans that you can see on the left-hand side at the top, assuming you can see my pointer, and the one at the bottom is that those scans have been taken 2 years apart. And in the middle, I am just showing a differential image, and we can clearly see, looking at, clearly see when we've been looking at it for 10 years, we can clearly see that we've got hyper and hypo intensity area on this differential image, and they are there, and they are telling us that actually the brain morphology has been changing. In this case, we are looking at atrophy. The brain size decreasing due to the neurodegenerative process. And on the right-hand side, these are the type of reports that we're able to generate, so that rather than having to manually interpret these images and trying to understand where are the changes occurring and how to quantify these changes, we present a comprehensive report to our clinical collaborators with with a lot of images so that they can actually QC at the same time as they review the results that we obtain. Another example on how image processing is used. So on the left-hand side, we've got a volumetric and a structural imaging of the brain. So that's a T1 weighted with a strong, strange contrast on the screen. But anyway, we are able to parcellate this brain into 200 plus sub-region, and this is a rotating brain that we can see in the middle. And from then, we are able to extract volumetric information about the patients, which we can then compare using a normative database to other populations, so to other individuals, so that we know for a given individual if there are more or less volume change or atrophy occurring compared to an healthy population. And from there, we are able to generate the type of report that you can see on the left-hand side, same thing, trying to have an easy and simple representation for clinician and to speed up the process of reviewing the scan. And the three figures you can see on the bottom right are basically derived from 3 scans and 3 individuals. So on the left-hand side, we've got a scan of an healthy subject. In the middle, we've got a scan of an individual that is starting to have some mild cognitive impairment. And on the right-hand side, we've got the scan of a patient diagnosed with Alzheimer's disease, where we can see that the atrophy, as we move on the right-hand side, is increasing. It's not as simple as that all the time, but for illustration, that's what we've got. And then we can use image processing to fuse modality, to combine all of the information. As we were saying earlier, if I take a CT of an individual, I will have good contrast about the bony structure, but very poor contrast of the about the soft tissue. If I take an MR, I will have the opposite. So it wouldn't be great if I could combine all of this information together, merge it so that I can present the clinician with everything in one aspect. And that's the work of Marta Ranzini, where she was aligning these images and then segmenting all of them and making sure that we have plausible presentation to the clinician. And what you can see on the right-hand side there is like you've got the bony area in white. We've got an implant there at the level of the hips, and then the colorful level are the muscle oriented. And we could use that to quantify muscle loss, fat infiltration, and all these type of things that could be side effects of the surgery and the presence of an implant. And another example, we can also use image processing to quantify change over time and actually see how the brain is evolving. So the way I generated these images, I took 2 scans from the same individual, a patient diagnosed with Alzheimer's disease, and the 2 scans were taken 2 years apart. And then we were able to, I think that works. Yes, we were able to assess how the scan was evolving over time so that we can provide information to the clinician, and they could actually, rather than having to interpret in their head, they could actually see how the brain evolved over time. So these are just a few use cases of how image processing are, and how image processing is used. And there are so many more. We can spend the day or the week speaking about it. But what I wanted to focusing for a few minutes are basically the toolbox of an image processor. And there are many tools that are being used. And I picked 2. The first one is segmentation, labeling and annotations. As you've seen in all of the use cases I showed before, we are effectively extracting information, identifying areas so that we can present it to clinician in a more comprehensive way so that they don't have to look for it. And the second one is the concept of registration, which is a way for us to combine information so that we can find spatial correspondence between images. And the example that you could see on the screen is that on the bottom left-hand side, we've got an amount of an individual before any surgery is done. So we've got all of the time that we want to process this image, to annotate this image, so that we can plan the potential surgery. And on the right-hand side, you've got the image that is acquired during the surgery. When the patient has the skull open, we've got an ultrasound probe at the surface of the brain, and we are able to detect features on the cortical surface of the brain. And we want to merge these two information so that we can actually take advantage of all of the information acquired preoperatively, sorry. And in order to do that, we need to know how they are aligned. And this is this concept that we call registration. So I will come back on registration, but first, image segmentation. Just a few things that are, I think, specific to our domain and dealing with medical images. And this is just an example of an algorithm that is commonly used, or was commonly used before deep learning took over, for the purpose of segmenting the different tissue types of the brain. Where, in a nutshell, on the left-hand side, we've got an image, which is a scene, which we want to segment into, in this case, gray matter, white matter, and CSF, which is the fluid area that you can see all, at the middle and all around the brain. And what we are effectively doing is that we are going to run a mathematical model on the top of this image using something called a Gaussian mixture model, so that we can actually, at the same time, identify the intensities that are similar, as well as characterize these different intensities. And there is a lot of, Bayesian inference that is done behind it, where we use population priors to guide our algorithm. We've got Markov random field denoising, so that we make sure that we don't have this speckled noise that you can see in the middle. And at the end, this algorithm is used to obtain accurate segmentation and has been used extensively within our field. However, it's not one-to-one-all type of algorithm. We can't take this algorithm and apply to all of our segmentation needs. So a lot of different approaches have been developed, and something which has been as well quite popular is the use of active shape models, where, assuming that I have a large population of a large amount of data already segmented, I can generate using various techniques, principal component analysis being the simplest and one of them commonly used, where I can actually have an average shape representation, as well as learning how this shape can vary within my population. And then I can use this model to segment a new image, so that by changing the parameters of my model, I can try to match it to the object I want to segment. And again, there are many more. People are using snake, level set, watershed, and a lot of different techniques have been used for image segmentation. So now, coming back to image registration, as I mentioned, this is the concept of trying to find point-to-point correspondences between images so that we can actually warp them. So assuming that I've got these two images that you can see, I can identify which point, which voxel, or which pixel, or which tessel correspond to which in the other image. Then I'm able to actually deform these images to make them alike and extract potentially information from them. And the reason why I'm mentioning registration, well, it's twofold. First, I'm completely biased because that's my area. But second, it's something that is commonly used when we deal with image processing. As soon as we've got two images, it's not unlikely that we need to align them to really take advantage of them. And as a result, it's used throughout all image processing pipeline. Every analytical pipeline dealing with images could potentially be taking advantage of image registration. Starting from image acquisition, where we are going to focus on one single subject and try to improve the acquisition by aligning it, up to all the way through the spectrum. I won't go through the list here, but where we do large population studies, where we've got hundreds of patients of one population, hundreds of patients of another population, and we want to contrast and compare these two populations. And so the examples that you can see on the left-hand side bottom is a reconstruction algorithm for reconstruction of fetal images, where during an acquisition, the baby will be, or the fetus will be moving a lot, which doesn't help us to reconstruct a nice volume of the head in this case. And what Michael Ebner has been working on is a way to align these images as well as reconstructing it. And on the right-hand side, we can see an example of analysis of two populations where we are able to identify the specific area within the brain that are effectively different in terms of morphology. So most registration algorithms are following the same steps. They pretty much all work in the same way. First, we need to identify a transform model We're going to deform the image so that we maximize a cost function or a loss function nowadays. And this is done through an optimization scheme where we change the model of our transformation to maximize the similarity. Now there are a few challenges where that requires expertise of imager, where we don't really have a formula to say that two images are well aligned. It could be obvious when we've got the images at the top there on the right-hand side, where they are effectively, we've got images of similar contrast and intensities. So just an L2, a difference image, and we want to negate this difference, seems appropriate. But if we look at the images at the bottom there, where we've got two MR acquisition, but different pulse sequences, so showing different information, it's not easily, well, we can't easily find a linear relationship between the intensity. So we need complex model to be able to characterize and quantify what is a good alignment. And as well, we need to know how we want to deform our image. In some cases, we just want to change its position in space. In some others, we want to apply very high frequency transformation so that we can really non-linearly deform images and everything in between. So we can have algorithms that have 1 degree of freedom if I just want to optimize translation, up to algorithm with millions of degrees of freedom, commonly used where every pixel or voxel can move independently from its neighbors. One popular approach that's just to illustrate how this can be done. One popular approach that's been proposed by Daniel Ruckert some time ago is a freeform deformation technique. And on the image on the left-hand side, you can see a grid or lattice of red crosses. And they are effectively anchor points that will be used to deform an underlying image. And at the bottom left of this image, you can see a blue dot. And effectively, to generate this video, I move the blue dot to the green location. Not too obvious. Okay, well, it's even less obvious now. It's gone. I move this dots to the. Here we go. I move the dots, and what we can see is that it's actually locally deforming the image on the right-hand side. And now we can consider that if I start moving all of the red crosses at the same time and optimize their location, I'm able to fully deform my image on the right-hand side. So this type of algorithm, I've been fortunate enough to implement an efficient version of it some years ago called NiftyReg. It's an open source package, and we've been able to use it through a wide range of application and body parts on human, on small imaging, but as well using it for histology. However, same thing. We don't really have a Swiss Army knife of registration that can be used for everything and anything. So there I've got two examples of work on the left-hand side, work again by Marta Renzini, where she developed a scheme where she wanted to align MR and CT of the hip. And within the hip, we've got bones. We know that the bone cannot be deformed rigidly. Locally, it's a rigid structure that can move at once. And we've got a lot of soft tissue. And so she developed a scheme where she could combine both this information to have a dedicated transformation model. And similarly, on the right-hand side, work by David Dromey, where he developed a transformation model dedicated to the spine, where every vertebra is able to move rigidly, having some coherence between the way two vertebrae nearby move together, but as well being able to deform everything around it in a local manner. And this is just an illustration of what could be done with this transformation model. Another example is the work by Yipeng Hu, friend and colleagues from UCL, where he focused on the alignments of prostate imaging. So we've got MRI and we've got ultrasound. It's really hard to find first a feature that matches, but second, to find a numerical way to assess the quality of these images. So, and we are very likely to overfit, and it's an optimization nightmare if we were to use statistical techniques. So we developed a dedicated scheme to this application where you can create a 3D model of the prostates and then start deforming this model with known parameters that it run from simulating the possible deformation. And by doing that, he was able to transfer information from the MR so that we can identify the gland, but as well potentially the tumor area on the ultrasound, despite the fact that we were not able to actually see them. So now things have been changing, and what you can see in front of you, I went on Scopus and I wrote deep learning or machine learning and medical imaging, and I extracted the number of papers per year, and this is a trend we are in at the moment. So you can see that over the last 10 years, or not even that, we had a substantial increase, I think it's fair to say, in terms of number of papers that are using machine learning. So we had a bit of a shift in our domain, moving from little learning in 2010 to, well, a lot nowadays. And there are a lot of papers that have been published on the topic, and I'm only going to focus on these two for now. But basically what happened is that nowadays, deep learning approaches have been replacing the non-learning approach, some of the non-learning approach that I've shown you before. A typical example of a very popular architecture is something called UNet. Most of you might be familiar with it. You can see that it was published in 2015, and it has over 23,000 citations, which is decent. And this is an architecture that you can see on the right-hand side, where we've got two branches. So an encoding branch on the left-hand side, a decoding branch on the right-hand side, and then what we refer to as skip connection, so that we can propagate information from one branch to another and have good resolution output. And this is a technique that is typically used to segment images, where we have a supervised manner. We train an algorithm to actually, from images, detect region of interest within our image. And registration is not at the stage where it's completely replaced by deep learning approach, but we also had very popular framework. One of them is called VoxelMorph by the team of Adrian Dalker, and same thing, it's been quite popular, and it's a framework where, given two images, they are able to predict the deformation field, and they are going to predict the transformations that's best align the two input images. So one of the advantages of this approach is that instead of taking minutes or hours, we've got results within seconds, which is amazing when we want to have very fast outcome. If I'm doing a surgery, or not me, if I'm seeing a surgery, or if I'm the patient, I don't want to have to wait 5 hours so that the algorithm finished. I'd rather have it in real time, and this enables this type of application. As well, if I need to process 10,000 scans, even if I've got a big cluster, it's going to take a while if all of them are taking hours. While there, we can have lots more analysis being performed in a reduced amount of time. But deep learning didn't only enable us to replace the existing technique, it's also creating new opportunities and things we couldn't really do before, at least not in an easy way. And this is an example of the work by Felix Bragman, where given an input MR image that you can see on the left-hand side, so that's at the level of the hip, he was able to generate a synthetic CT, which is used for, well, attenuation correction when it comes to radiotherapy planning, but as well some segmenting some region of interest. But not only was able to produce what we could do before, but he was also able to predict the uncertainty associated with this answer. So we are speaking about aleatoric uncertainty, epistemic uncertainty, basically the uncertainty associated with the model. The model is able to tell us, well, I'm not too sure about my result in this specific location, or the model is able to tell us, well, I've never seen this case in my training, so I give you an answer, but take it with a pinch of salt. And this is really, that could be potentially be valuable information that we can later use to our advantage to provide more guidance to our clinical collaborator. Another thing that could be done, so still the work of Yipeng from UCL, Yipeng Hu, sorry, where he took advantage of the fact that he had a lot of segmented data But when we need to do the intervention, we don't have the time to segment the area of interest. So what he did still for his MRI to, well, what we did there for the MRI to ultrasound registration is to leverage on the fact that we had a lot of label data. So we had an algorithm, so that gave us a transformation which was trained to align two images so that it aligns landmark and segmentation and key points that we already had in advance. And then that means that at inference, when we later need it on unseen data, we are able to use this algorithm, and it will give us the best transformation that would have optimized label overlap or maximized, label overlap or key point overlap without the need of those key points. And then last thing, we are also leveraging an adversarial technique because we've got a lot of data, but we don't have a lot of data necessarily annotated, which is a challenge of our field. We don't have an ImageNet equivalent of medical imaging yet. It's going to come. But so what Marta Ranzini has been able to work on is to actually leverage on MR and CT to remove, not only correct artifacts, but actually synthesize what would have been the underlying MR if the patient didn't have an implant, so that then we can later use these images using traditional techniques without them being negatively impacted by the artifact present in the image. So now that we've got AI as one of our toolbox, there are a lot of opportunities to maximize the impact we can have on the healthcare system. And here is just a simple list. So we can improve, we can use it to improve on patient care. So better tool for diagnostic, better tool for prognosis, providing guidance to the clinicians, but we can also provide them with guidance so that we speed up their process. They can actually, they've got a companion on the side, an AI companion that is giving them potential indication on what needs to be done and what can be done and where we've got abnormality and all these type of things, so that we can actually help to address the fact that we've got a bottleneck of radiologists or clinicians at the moment. We generate more data that we can review. So we can help there, we can try to help. But we can also help the hospital or the trust as a whole in a way that auditing of services, of scanner devices is a lengthy process. A lot of it can be automated when we've got access to the data that we can crunch and process quite rapidly. We can help on operational efficiency. So giving you an example, if I've got algorithms that are able to predict that based on all of the patients that we've seen in ER, 2 weeks after we will need a given number of beds in a specific ward, I can already reallocate the staff. I can make sure that I've got enough bed, and I can organize the full hospital based on this type of information. And of course, we can also try to improve the value-based proposition of the healthcare so that minimize the costs while maximizing the benefits. However, some or most of you may have seen papers and blog similar to the tools that I just picked here. So we've got a lot of tools. This has been highlighted by COVID, where we all went and developed our tool to identify COVID and sort the world. And at the end of the day, none of them really reached clinic, and for multiple reasons. But the fact that we don't have the tool to integrate our algorithm from our laptops to a complicated clinical environment, a lot of the analysis that we've done was rushed. We've got serious bias, and we've got poor validations. And this is something that we would like to change. And one of the trouble when we go from research data to real, or both real, or to clinical data, is that we are changing data. It's not really as nice, as pristine, as curated as the data we use to train our algorithms, and everything is going to be impacted negatively there. So a lot of the research is about identifying a specific pathology. But if we look at the real environment, we don't deal with one pathology against normality. We deal with a wide range of pathology. So we need to be able to do differential diagnostic. We are dealing with corrupted data where we've got different field of view. So the 4 images that you can see on the right-hand side here are us going on a PACS and asking for 4 MRI of the brain. So we've got a brain where half of the brain is missing within the skull. We've got highly corrupted images with motion. We've got CTs of the head. We've got head and neck area where we don't have the head. Obviously, that's not the norm, and I took the outlier here for illustration purposes, but also I've seen scans of legs. So the data is not as pristine and curated as we are used to. So we need to work on that. And we've got a lot of missing data. We need to deal with imputation. So there is really a gap between what we do in research and what's actually happening in the clinic. And we want to bridge this gap. And to do that, we are part of an initiative called the London AI Centre for Value-Based Healthcare, which is a relatively large project that involves several universities, 10 hospitals, and as well companies. And our aim here is really to find a way to close the transitional gap so that we can move tools from the research, whether it's companies or university, into a clinical environment. And to do that, we've identified a few pillars that we are trying to focus on. I'm not going to go into detail to all of them, but so we are trying to develop software tools and infrastructure to make sure that the data we've got large interoperability within an hospital, because we've got data coming from different sources. Obviously, we've got imaging. But we've got clinical data, we've got genetic data, we've got wet biomarker in the shape of blood sample, we've got demographic information. Potentially, they are still nowadays on different systems. We need to collate them, we need to create them. So we need the infrastructure to be able to do that, so that we can make this data research ready somehow. There is a lot of ethics and governance that we have to go through. So we want to create blueprints so that we go through and then everyone else can speed up the process by creating, to-do and SOP that can be followed. We need computational capacity. Everything we do is work on large GPUs, large computational power. And usually hospitals don't have that by default. So we are deploying this infrastructure within the hospital so that we can run our models. We want to make sure our models are safe. I will come back on that. We want to foster collaborative research. I will come back on this point as well. And we want to facilitate deployment. That's a key aspect, facilitating deployment of tools first so that they can be evaluated. Because this is a big gap that we've got at the moment. We don't evaluate our tools. Sorry, I'm being quite generic. I'm sure some people do. In general, our research stops when we've got the journal paper. But we want to facilitate the adoption and the validation within the clinical environment. I'll just keep that for time. So to facilitate collaboration and to make sure that everyone was developing tool or is developing tool to very high standard, in collaboration with NVIDIA, so King's created the MONAI project. This is a project about developing a software platform dedicated to healthcare AI application with a strong focus nowadays still on radiology. And initially it was King's and NVIDIA, and now we've got collaborators throughout the world that have actively contributed to this platform. And really this platform, our aim was to put all of the good practice we could identify, or the community could identify, into a single piece of software that can be used, but as well all of the know-how of imaging experts. Because going from standard, well, I don't want to say it in a mean way, but going from computer vision, where pixels don't necessarily have a unit when you look at a photograph, to medical imaging, when pixels potentially have a physical units that has a meaning. We've got orientation that is relevant. We've got different voxel size. So not every voxel is 1 by 1 by 1 unit. There is a millimeter scale behind it. So those are just examples, but just making sure that all of this type of concept were implemented in the tools that we've got. And as well, developing tools so that people can do reproducible research, so that there are common pipelines that can be used to compare and contrast algorithms and the different bits that constitute an algorithm as well, up to having a deployment engine, so that people writing software for free, they are able to deploy it within a clinical environment with this MONAI deploy. We are really keen on collaborative studies. When dealing with machine learning, I mean, often the more data we've got, the better it's going to be, because we want to learn from as large population as we can. And the data at the moment is, a lot of the data is within the hospitals, and it's quite complicated to share data across hospitals. There is a lot of regulation. At all costs, we need to preserve patient privacy. When we know that anonymization is not that straightforward. Either we remove core information about the data that could be useful for the application we've got in mind, or we don't really anonymize. And to alleviate this, we've been pushing for a federated approach as opposed to a data lake approach, where instead of having the data centralized, we make sure that every site is, I think I've got myself one. No. Every site is actually keeping their data, but we don't move data across, we move models across. And we are able to, with the infrastructure that we are deploying, to make sure that if I've got an hospital sharing data, the data stays within each individual hospital, but we can train models in a way that's data with privacy layer, so that nothing leaks from the hospital, but we can train model with all of the data that's available. And in order to do that, we've been developing FLIP, which is a federated learning interoperability platform that's made of a few systems. So we've got within each trust, so on this slide, I'm highlighting two of them on the right-hand side. Within each trust, we are deploying a secure enclave, which is within the hospital firewall, where we've got here 3 components highlighted there. So on the right-hand side, we use a software called XNAT, which is basically an archiving system for medical imaging and clinical data. We use CogStack, which is a system that can ingest textual data, PDFs, any type of data that's non-imaging, basically, and through Elasticsearch makes sense of it. It's a bit of a shortcut. It's a big shortcut, but it's a Google of the hospital, in a way that you've got your search bar and it can be interpreted by pulling all the data from the different sources. And then we combine these informations through a strong ontology, and then that means that we harmonize in the different hospital how the data is actually structured, so that then we can have our AI model trained locally, because we also deploy computational infrastructure within the hospital, and we can train this model together. And because the secure enclave is the same, the data is presented in the same way, and we actually can create an API so that they can communicate throughout the different hospitals. Oh, let's see if that works. So one of the issues that we've got when we are sorted, it doesn't. You will have to trust me, I apologize. So one of the issues that we've got with medical data is that potentially when we are embedded within an hospital, we could have access to a lot of data, because there are a lot of patients and all of the data is stored on PACS if we speak about medical imaging. But we have very little annotation. Segmenting imaging manually is a very cumbersome task, and it takes a lot of time. And again, in collaboration with the MONAI project consortium, we developed MONAI label, which aims is to assist, using AI, the process of labeling data. And the way this works, and I'm not going to mime the video, it's on YouTube, you can just Google it if you want to. What happens is that the software will present some data where a clinician will start segmenting the data. And the first one is going to take a lot of time. But when this one is done, the first one will go in a queue. It's going to be used to train an algorithm that will then predict the segmentation of the second one. And then we've got the possibility to do minor edits, to add some data within the foreground, remove some that should be in the background, And when this one is finalized, it goes in the queue. So as we go, we expand the amount of data used for training. And the more we do, the faster it goes, because the algorithm becomes better and fewer annotation are required. The video is quite cool, actually, if you want to go after. And lastly, so the last point I wanted to make is the second aspect of the platform that we are working on within the AI Center. That's a deployment ecosystem. So this is key for us to be able to make sure that tools that are being developed are actually implemented and used and evaluated within a clinical environment. And that's where we developed a platform called AID, standing for AI Deployment Engine, that relies on some of the technologies that I showed you before, and that enables to easily deploy an algorithm within the trust so that it can be embedded within a clinical workflow. And so there we can see a list of applications on the right-hand side, going from X-ray to cardiac images with dementia and stroke. So this is a pathway that we are working on at the moment, and that we are using as blueprints. So we want to deliver a few pathways, but do it well, and then we can replicate the story across a different pathway, clinical pathway within the hospital. And the first pathway that actually has been through the process is a work led by George Cardozo, Parshkev Nashket from UCL, and Seb Urselund from KCL. So it's a stroke clinical pathway. Let's see if this video works. Should be good. So there, what I'm showing you is actually the system as it is deployed within this one was within KCH, within King's College Hospital. So we've deployed this system in September 21, and our aim is to deploy the system in the 10 trusts we are working with by September 23. So I'll just run you quickly through the video. So this is the system as we can see it. So from there, the clinician has the possibility to go to their PAC system, so they can view their image. They've got the possibility to go to their PAC system, and what is happening, sorry, here we go, PAC system. From there, they're able to send the data to AID, which is a platform. AID recognizes that we're actually dealing with the brain automatically, recognizes the type of contract that is used, and from there, we'll offer a list of potential AI tools that can be used. The clinician will select the tool. Now it's going faster than me. And then a report is generated. It's embedded within a DICOM. The clinician can review the report. That's the QC steps to ensure that actually the algorithm didn't go wrong, and then can reject it or accept it. If it's accepted, it's going to be automatically added to the record of the patient, so that all of this information is actually there. And that's been meaningless integrated within the platform, and now we also implemented all of the admin aspect and the management of the system, which is also quite key for the people managing the system within their own trust. So they've got full control of everything that's happening. So. Sorry, it went really quick on a lot of topics, at least for me. I hope it was done for you. But in conclusion, we discussed that the fact that over the last few years, 6, 7, our field image processing has been changing rapidly, going from a few uses of machine learning to a lot of using of machine learning throughout every application. And really, this type of tool benefit from very large data sets, which we didn't typically have. I mean, when we had hundreds of patients, that was on average quite good at the time. And now we are keen to deal with more patients. But all of this data is actually embedded within the trust, and it's not as nice and as pristine as our research data. So we need to make sure that our algorithms are able to cope with that. But this is really creating a lot of opportunities for us, so we can change a lot of things in clinical care. Before, a lot of our focus was about taking an image and generating a novel biomarker or doing some surgical guidance. Now we can actually develop tools that will not only use images but impact all of the hospital ecosystem. And in order to do that, we think and we identify as a problem that we did not have enough collaboration between the universities developing the tool, or potentially developing the research and the techniques used, the hospital needing the tool, as well as the companies, which are the ones that will take research, implement that as software tools that can be used. They will do the CE marking, the FDA approval, and all of that. All of these parties need to work together, and that's what we try to do with this London AI Centre for Value-Based Healthcare. And what we aim to do is to close this translational gap so that we can foster translation of techniques and really creating blueprints with our university and hospital collaborator, so that then it can be disseminated to all other trusts. So all of the platform and all of the code that I've showed you is open source, and this is our aim, that it stays the same, so that people can then take it and use it within their environment and somehow join the club of Federation and decide if they want to contribute data and join this Federation of Hospital to develop and integrate AI tools. Thank you.
Thank you very much, Marc. It's really fascinating, and especially the development of the London AI data center. And I think to see it actually going from research to the bedside clinical care, and I think it's really fascinating to see, especially the fast development in the last few years. I remember one of the slides you indicate the number of publications and the research output in the last few years. It's really amazing. And do we have any questions from the audience? So if you are joining us online, you could raise your hand, or if you want to type in the chat.
Firstly, I apologise for being late, but one of your slides that I saw, it was concerning data, and anonymised data is not consistent with the real world, as you said in your slide. But personal information subject to DPRA with permission that can be used, which would influence the lack of normalization of the anonymous data. It can be incorporated. Why is that not being done?
So actually, this is exactly what we are trying to do. So within the context of our AI center, we've got several ethics that are granting us access to all of the data that is effectively within the hospital, subject to control and engagement with patients and review of the project, so that we make sure that it's actually ethical. But we are able to run our algorithm within the trust. And this is effectively why we took this approach of keeping the data within the hospital rather than pulling it out, so that we don't need to anonymize and remove all data, because the data is staying at its source. It's not actually leaving the hospital. And the other ethic that we've got is more about being able to anonymize data thoroughly and extracting it and using it within our university, but it's more of a sandbox to develop algorithms. So if I want to create an algorithm to do segmentation of a specific area of the body, I don't need all of the data about the patient, I just need the image. But if I want to develop the tool within the trust that will help me to do any diagnostic or prognosis, I want to be able to use all information available. And we think that through thorough anonymization process, when we do that, we discard some information which is actually quite relevant. So that's our way, that's why we privilege these techniques, so that we are fully compliant with GDPR. We've got extra layers to preserve data privacy within our federation. And so that's the two approach that we've taken. So we actually don't need to thoroughly anonymize the data in our framework. You don't seem convinced. Can discuss that after, maybe.
Thank you.
Yeah. Well, thank you. I think just for the time being, we will continue for the next speak, because we will have sometimes at the end of the talk to have a bit more general discussion. So next, our next speaker is Dr. Qianni Zhang, and I think we will try to see how to share here.
That's
Is the part is there? Yeah. Yeah.
this one.
Yeah, that's the PDF. Yeah. Great. Thanks, Marc. And so our next speaker, Qianni Zhang, and Dr. Zhang is currently a senior lecturer in the School for Electronic Engineering and Computer Science in the Queen Mary University of London. She has 18 years of research experience in the field of computer vision, image processing, and also machine learning. She works on solving diverse cross-disciplinary problems involving artificial intelligence, and especially using such technique to facilitate access to the large amount of medical image data. In her talk today, she will showcase a few ongoing research projects that use computational method to assist or automate medical imaging-based assessment, diagnosis, and also treatment procedure in medical research and clinical practice. So, welcome.
Thank you, Ruby. So do I have 45 minutes?
Yeah.
Okay. Okay. Hello, everybody. So I'm Qianni, and I myself come from a computer vision background. So originally we use image processing and analysis to help us to serve different purposes. So the application domain could be entertainment, could be security, traffic, fashion, and so on. Later on, I started to more and more shift my research purpose towards using such techniques, computer vision and machine learning, to solve medical image understanding tasks. So because I myself come from the computer vision background, I'm gonna approach this topic today through the computer vision's perspective. So thanks to Marc's presentation, which gave us a very, very nice overview and a lot of discussions in the particular field of medical image analysis. Now we have been now we understand very clearly that there are a few main questions that we need to resolve in the field. So from a computer vision point of view, there are a few main tasks: classification, detection, segmentation, alignment, and so on. But when we look at the analysis of medical images, we realize that actually segmentation is probably one of the most important task that we need to look at, because it is a fundamental step that will be needed before any subsequent analysis can take place in medical images. So in general sense, segmentation means that we want to partition the digital images into multiple image segments. And traditionally, we want to segment images according to their regions. But while the research is developing, people realize that that's not enough, because we as human beings, we perceive the world around us visually according to our semantic interpretation. So what we want to see are objects rather than regions. If we have segmentation based on regions, we might segment one single object which has a surface of different colors or visual patterns into different segments. But in actual fact, we as human beings, we think this is a single object. Or in other sense, maybe the object has a uniform surface, but there is some shadow on it in part of its surface, then this may also be segmented into different regions. So later on, people moved their focus onto the question of how do we segment images semantically, so that it matches with a human interpretation. And also with progress in deep learning, it is now possible to even segment the images based on a pixel level. So basically, we analyze the class membership of every single pixel and try to group the pixels, the neighboring pixels falling into the same class, so that we can obtain a pixel level segmentation, but focusing on the objects. So coming back to medical image segmentation, there are many special considerations. First of all, the structures that we want to segment have to have a clinical relevance. So this could be organs, could be tissue, could be some lesion, depending on what we need to do with respect to a particular image modality. And there are various technologies that we can employ, and as Marc mentioned, many of them already. For instance, UNet is one of the mainstream segmentation networks nowadays, and there are a bunch of variants based on UNet. And lately, people have been using attention gating mechanism to allow us to focus on particular regions of interest in segmentation, so that the regions of interest are have more attention and will achieve better segmentation accuracy within them. And in around 2017, Google published an article titled "Attention is All You Need," where for the first time they presented the transformers, which is basically a self-attention mechanism. But it was initially proposed for the purpose of language understanding and processing. But researchers in computer vision then went on to adapt transformers for vision analysis. And therefore, we have a series of vision transformers that can also help us to achieve progress on segmentation. And there are quite many other deep learning technology, which I will keep mentioning later on, like similarity learning. If you haven't heard about this, you probably have heard about Siamese networks, like adversarial learning. You probably have heard also generative adversarial networks, GANs, and also the co-training methods like using teacher-student networks, and so that the collaborative training is enabled. Okay, so let's have a look at a few examples on medical image segmentation. So histopathology image segmentation is the very first project actually for me that opened the gate on medical image analysis to me. So we started this project on colorectal liver metastasis segmentation in collaboration with liver pathology group at Karolinska Institute in Sweden. So colorectal liver metastasis is one of the main type of liver cancer. And the way that the pathologists grade this CRLM cancer is that they try to by analyzing the histology slides, they try to quantify the percentage of the actual cancer cells inside the whole tumor, the whole metastasis. And the second way that they do is that they try to look at the invasive front. So how is the cancer developing? Is it developing by just pushing into the normal tissue, or is it developing by replacing the normal cells? So by looking at these different features, they are able to, they have a grading system so that they are able to decide on which grade each case is on, and they are able to define their treatment plans for every patient. So for both types of characteristics, the first step that we need to achieve is to segment the different tissue regions inside a whole slide. So the relevant tissue types here are like hepatocyte, which is represented by the pink. So this is normal liver tissue. And the fibrosis here is represented by the gray. And this is fibrosis tissue that's normally inside the metastasis area. And obviously we have the tumor, we have the cancer region, which is, I think here is the brown color. And the necrosis, the necrotic core, which may be the dead tissue inside the cancer. And a few other tissue types as well, like inflammation, which are very likely to turn into cancer, and blood vessels, and macrophages, and so on. Okay, so we have these multiple tissue classes that are relevant, and we need to segment the whole slide scans into according to the tissue categories. We're showcasing this particular task, but actually the development methods are also applicable, and we have tried to use them in other types of cancer as well, like breast cancer, lung cancer, pancreatic cancer, and so on. Okay, so this method that we developed, actually this has been a few years old, is called multi-scale context-aware network for semantic tissue segmentation. So the main idea is that we employ unit segmentation network as our main network, and then we try to fuse multiple scale features within the overall process. So here, as you can see in the network, we have two pipelines. So we approach the problem from two levels. First of all, on the tissue level, so we try to directly look at the tissue regions and perform pixel level segmentation on the regions of interest from the slides. And we also have another pipeline that's on the cell, focusing on the cell level, where we identify the cell nuclei, and by grouping the cell nuclei of different categories, we try to identify the tissue regions and their boundaries. And then later on, these two levels, the outputs of the two pipelines are fused to generate the overall result. And at the time, we achieved pretty good performance in terms of the accuracy, segmentation accuracy, and pixel accuracy, and intersection over union. And we have compared results with state of the art at the time. And maybe from the quantitative analysis, it's not so impressive because we didn't have that much of, actually, much of analytic data at the time. But we send the results for the liver pathologists to look at, and they use the segmentation output to help their clinical research. So the first thing that they do is that they have the whole slide images that's taken from a sample of the liver. And then this is obviously digitized and sent to us. By the way, these images are extremely high resolution. And if they want to visually examine such an image, it's almost an impossible task. So what they do normally is that they pick out small regions of interest from the whole slide images, and they do the visual analysis. And this is the same for us. When they generate the ground truth data, they can only draw the ground truth boundaries on small, tiny regions inside the whole slide. So by using that ground truth data for training, we achieve the segmentation. And as we can see, the main here we have two tumor areas, one on the left and a smaller one on the right, and the pink area in between is hepatocyte. And we also have some background regions. So the first step that we need to do, as we said, we need to, based on the segmentation, we need to quantify the proportion of cancer cells inside the whole metastasis area. So we remove the hepatocyte and we remove the background regions, and leaving us with only the tumor regions. And then, because we know how many pixels belong to the brown regions, we are able to quantify the proportion of the cancer cells. And in the next step, they will try to identify the type of invasive front. So this is also achievable based on the segmentation results by looking at what tissue region we have, what tissue category we have on both sides of the boundaries. So in this particular case, if you see this green boundaries, it's where we have the desmoplastic case. So this is basically in the case where you have the cancer, but the cancer is wrapped up by a layer of fibrous tissue so that it's not directly contacting the hepatocyte. And this is considered to have a better, slightly more fortunate outcome because it's less aggressive. Now, in some other cases, you will have boundaries where you have the direct contact between the cancer and the hepatocyte. So the way that cancer develops in this case is that the cancer cells replace the normal cells one by one, and this is considered a much more aggressive case. Also, we have a few other cases like the tissue boundary, and this is basically the tissue boundary along the background. Okay, so we send these results to our collaborators at Karolinska and received very positive feedback. And the project is still ongoing. We're trying to develop more advanced methods nowadays and trying to achieve even better segmentation outcomes. But there are quite a few challenges in terms of segmentation in histopathology images. First of all is the data collection. So just digitizing the whole slide images is not a trivial task. Not to mention that to share the whole slide images with cross-disciplinary collaborators, we require data protection, we require ethical approval, and so on. So that has been always a challenging task for us to even collect and share the data. And even more difficult than collecting the data is to obtain the data annotation. We mentioned earlier that it's impossible for the human experts to annotate the whole slide images. Rather, we pick up some smaller regions which they think are most important, and then annotate the boundaries inside them. But even this small amount of annotation is extremely time-consuming and requires a lot of experience of the annotator. And it's also influenced by the inter or intra-observer variability. Apart from all this, there are also challenges because of the nature of the data. For instance, different from object segmentation, here we are segmenting tissue regions. And normally there's no rigid, clear boundaries. And the boundaries are soft and weak. So it is sometimes impossible, even for the humans, to determine where actually the boundary is. And also we have the presence of many smaller regions of particular tissue types, like the bioducts or blood vessels, which are small and difficult to spot and segment. Also, in some very challenging cases, there will be coexisting tissue types in the same region. The cells belonging to different types, they present in the same regions, and it's almost impossible to segment it. And we also face the technical challenges that's commonly faced in the deep learning-based segmentation, like the computation could be very intensive, and there will be subjectiveness in evaluation, and so that's very hard to encounter, to overcome. Yeah, so the previous project is talking about segmentation of static images. But we know that in medical domain, a lot of the capturing process is not static, it's dynamic. So here I'm showing another example where we try to analyze the image sequences. So this is a project on the analyzing the intravascular ultrasound image sequences for coronary artery disease. So as we can see in this example on the right hand side, here we have one image from the sequence. So what they do is that they put in a catheter which can emit ultrasound into the patient's vessel, and they pull back the catheter at a constant speed, and along this pullback the images will be captured. And by looking at the images, they can obtain a lot of very important features. Ultimately, what they want to do is that they want to assess the situation of the plaques inside the patient's vessels. So we know that the plaques ruptures is associated to a lot of the different types of disease in cardiology. And so the very important aim here is to understand how the plaques are developing in the vessels. But for the human experts, the cardiologists, their first step is always to identify two boundaries. The first one is the red boundary here. That's a lumen boundaries where the blood can flow through. And the second boundary, which is outside here, the yellow boundary, is external elastic membrane. So this is the vessel, external vessel wall. And between these two boundaries, there is a region where you can find the plaques. Okay, so their daily practice is to find, first of all, find the key frames, which are called the end-diastolic frames in IVUS sequences. And then on the key frames, they manually draw these two boundaries. Okay, so naturally, it will be very tedious and time-consuming job, and it's very difficult to guarantee the accuracy and the objectiveness in this process. And therefore, we started working together, trying to develop automated computational models that can achieve this. Our collaborators in BATS, they collected around 500 IVUS videos for us at the moment that are from 170 patients, and this number is still increasing at this moment. And for the sequences, they annotate them with by 3 human experts. So we obtain these boundaries on the end-diastolic frames for training and evaluation purposes. Now, the difference in this task compared to the previous task is that we're looking at the image sequences. So there's a temporal domain that we need to take into account. This is actually very important as well for the human cardiologists, because some of the boundaries are very difficult to identify, and it becomes easier when you browse through a small sequence of neighboring frames around the end-diastolic frames. So they browse through these frames, 3 or 5 of them, and then they can, they can gain help in identifying such boundaries. So these are the features. These are the most kind of motion dynamic features that we want to also pick up for the computer algorithms to perform the segmentation. Here we show a few examples. First of all, we face different challenges posed by the data itself. The images come with pretty low quality, as we can see, and the boundaries are very difficult to identify, first of all, but they are also missing in some regions, especially when there are in some dark regions, especially when there is presence of the calcific plaques, then this will block the penetration of the ultrasound, and therefore you will have a shadow area here. So if we know that if the computer is not able to pick up the visual features, then it is not able to do any prediction. But we, as human beings, we have excellent visual perception, and according to the Gestalt laws of visual perception, we as human beings, we have the ability to naturally close the gaps when there are missing visual stimuli. And also we tend to perceive the visual elements in the terms of overall complete organizations or structures instead of separate elements. So we want to leverage this kind of ability, but we want to mimic this kind of ability of human beings in our computation models, so that we can predict the boundaries when the visual information is actually missing. Also, there are other challenges, like we might have a lot of artifacts that's generated by, that's introduced by, for instance, the side branches. It's where the side branches come and meet with the main vessel. And we have the artifacts that's created by the guide wire effect and so on. So we mentioned that we want to leverage the motion features. So we went intuitively, we went to first study the traditional motion features like optical flow. So on the very left column, you see the original images, the single end-diastolic frame that we want to focus on. And on the right, you see the optical features that we extract around this frame. But unfortunately, not much of clue can be seen here. So we can see in this column, we have the human annotated boundaries. But through the traditional motion features, we cannot identify any useful clue to determine the boundaries. So we went on to explore other options. So the first thing that we tried is that we put 3 consecutive frames superimposed together, and we start to notice that some features start to visualize. Like we might notice there may be a boundary here because the 3 frames are superimposed, and you will also notice there's a very thin weight line starting to show here because yeah, we oops. What happened? Did I click on something? No, that should be. Okay, what's happening? It's gonna turn off. Oh, no. Oh, that's yours. Sorry. Okay.
That's right.
Okay. This is it. Okay. Oh, is it? No, still not trying. No. Okay. Oh, yeah, okay. 2. Okay. Yeah. So maybe it's not very obvious to see here. Some clues are starting to show when we superimpose 3 neighboring frames, and then following this idea, we try to develop a few motion encoders which are dedicated to this task. So there is a alignment encoder first of all, and there is a visual persistence encoder. So if you look at the encoded images in these 2 columns, you see that the boundary, the clues that indicating where the boundaries are become more and more obvious, and therefore we can identify the boundaries based on the encoded features. So I'm gonna show. Now here is a very brief, high-level illustration of the network, the framework structure. So we have, first of all, of course, the encoding scheme, as I mentioned in the last slide, and then we have the network. Actually, these are networks coming from 2 pipelines. The first pipeline is for the EM border. We mentioned there are 2 borders. And the second pipeline is for the looming border. So we basically use a unit structure, but we try to employ the most contemporary technologies. You probably have heard about selective kernel, SK unit. So we exploited that idea and we developed a selective transformer network. So here we want to achieve the best possible pixel level segmentation. And we also involve adversarial learning strategy. So this is the technique that we developed to tackle the task of, as I mentioned earlier, to mimic the way that humans naturally close the gaps from where the information is missing. So we call this perceptual organization guidance approach. And we also have a few other design considerations, like we have the post-processing methods to further enhance the segmentation, the boundaries, and we have the a method here to exploit the fact that we know the looming border is always inside the EEM border, so that we can correct some outlier mistakes in the segmentation. Okay, and then just to show some quantitative results, maybe it's not very easy to see the main difference from here, but we can see the last two rows are our results, and we have achieved pretty good outcome. And by the way, this is experiment based on the IVOS segmentation challenge with MONAI 2011. It's an open data set, so we have the opportunity to compare our own methods with a number of other methods. And this is for EEM segmentation, and this table shows the results for looming segmentation. And again, our method is in the last couple of rows, and we have obviously we experimented different setups, and we have very good results achieved with that. Maybe that's not intuitive enough, so I included some visual results. Now this is a illustration of the EEM segmentation. So the red dashed boundary is human annotation, and the green boundary is the predicted boundary. Now the first column is a unit with okay, we have the columns using different units with different losses, and then here we have the basic unit in this column, and in the last column we have the results from the proposed methodology. And we can see when the boundaries are smooth and there's not much of occlusion, the predictions from all models are pretty good. But when it comes to the cases of when it comes to the cases of some challenging areas like this one, so we have a shadow here, a big shadow here, and some shadows here, and some artifacts. The boundaries predicted by normal units are starting to drift away from the actual boundary. That's because the information, the visual features that we can pick up here are incomplete or misleading. So by using the adversarial learning scheme, we achieved much more stable results in such challenging areas. And as you can see in the last two columns, the boundaries are highly in line with human annotated boundaries. Okay, this is a few more examples to show both boundaries predicted in the same images. And this table on the right-hand side is a very interesting result I want to show you. Here we try to analyze the William index of. So the William index is a way that we analyze the agreement between different boundaries. So we have the William index between the two experts, and we have the William index between the expert annotation and our predicted boundaries. And as you can see that the automatic algorithm that we develop achieves a much higher William index. It means that both experts agree more with our predicted boundaries rather than agreeing between each other. So this is some very interesting observation, and it's a kind of side evidence to show that the prediction could be more objective compared to human annotations. So this algorithm, this training model, has already been included in a algorithm, in a software that's called QCU-CMS, and this is a software that's developed by University of Leiden. And this software with our model inside it is being now used by the cardiologists from multiple institutions, and they are now using it to save time in the daily practice and also to obtain better segmentation boundaries. Okay. Right. So. Start. 3 minutes. Okay, I'll talk quickly now. So in the last two examples, we're still looking at 2D segmentation, but actually, as Marc has mentioned, there are higher demand even in the 3D volumetric segmentation. So we also have a few projects in that aspect. So this is a 3D volume segmentation of the tooth in the cone-beam computed tomography, which is called CBCT data. So we started off by collecting some data set because there's no very good existing data set to use. And then we developed our own network, which achieves pretty good segmentation. Also, the segmentation output is used to reconstruct the 3D shape of the tooth. As you can see, these two columns in the middle in the red bounding box are our result. It shows a very nice surface that's that's highly in line with tooth the labeled data. And if we use normal segmentation methods, we will achieve the reconstructed results, which are very fuzzy and have lots of errors. And we also continue to develop better models using transformers, using collaborative training, and so on. Okay, so that was for segmentation, and we have a few other projects focusing on different tasks in computer vision, like detection. Object detection is a very big topic in computer vision, but when it comes to medical images, we also have lots of things that we need to detect in our clinical practice, like we need to identify the cells, identify the nuclei, or any other features or objects or structures that are of clinical relevance. But there are two main subtasks involved in detection. So first of all, we need to classify the category of the object. And secondly, we need to localize it. So we need to put a bounding box in the image to show where exactly the object is. This is a project that we use a technique in detection technique to identify the nuclei and the cells. So we know that in cancer staging, it's a very common practice that the pathologists need to mark the cells, mark the nuclei, and count them. But this is extremely tedious job. But on the other hand, it's extremely important. So we try to automate this process by using the deep learning algorithms, but we have to observe that there are very big technical challenges. First of all, the nuclei, they have very large variances in their features, their colors, their scale, size, and shape. As we can see, some of the nuclei and the signet ring cells in the second row, they are of very small sizes and very difficult to identify. So here in this particular work, we developed a similarity-based region proposal network. So region proposal networks is a very popular type of object detection networks. And we try to embed the idea of similarity learning inside it. The similarity learning aims to have a different way of representing the images. So normally we use visual features. We extract the visual features to represent our images or our units. But here in similarity learning, we try to represent them using the differences between a pair of positive sample and negative sample. So we call this difference feature embeddings. Now, our work here is that we use we extract the embeddings and we embedded, we apply it in the regional proposal networks with different salient backbones. Apart from the way that we use pairwise similarity, we also consider a different approach to extract the similarity between triplets. So the triplet is basically formed of anchor and a similar sample with anchor and a different sample that's doesn't belong to the same type of the anchor. So in both ways, we train the regional proposal networks, and again, some very good results based on the open challenge on multi-organ nuclei detection. In the table on the right-hand side, you can see that so in this challenge, they have assumption that we need to have generalized method that can be applied on different organs. So there are two levels of tasks. The first task is that you need to detect the nuclei in thin organs. So we train the model with our training set from certain organs, and then the testing set will be from the same organs, but they are different samples, but they are from the same organs. In the second task, they want to test how good your model is on the unseen organ images. So it means that we train the model with data from some organs, but then we test the models on data from different organs. So we achieved a very good result on the seen organs, but for the unseen organs, I think we achieved the second best result here at the time, and we are also very close to the top result. Some visualized results. The green are the annotated ground truths, and the yellow bounding boxes, maybe it's not very easy to see here, are the predicted bounding boxes. If you look in more details, you'll see that actually the proposed methods in the second row and the third row for triplet, for pairwise and triplet-wise learning achieves much lower false positives than the basic regional proposal networks. Okay, so that was an example of project in the detection field. We also used other techniques like alignment and 3D modeling to help solve the tasks, like we want to offer better enhanced visual assessments. And if we have very well reconstructed 3D models, we can use this in the augmented reality to guide surgeries and so on. We have a few examples of projects I want to showcase here. Okay, so this is a project that's coming from the IWAS project. So we know that it is possible now to visualize the 3D models of the main vessels with the help of the commercialized software that comes with scanning devices. But this is not as easy as it sounds, because first of all, the methodologies are semi-autonomous, meaning that they require human intervention. The human experts have to use their experience to pick up a small section of the vessel that they want to reconstruct in 3D, because the softwares are not able to reconstruct the full vessels, the main vessel plus a branch and so on. So this involves the human intervention to pick up the most important section, but also the localization of that section becomes a problem. And we know that we have some existing data which are less difficult to obtain, like the 2D quantitative angiography. So we could have a pair of those. One is taken from the front view and the other is taken from the side view. So in these images, you can see the vessels around the heart. And we also know that we can have the IVUS sequences captured, as I mentioned in the last project, and we can obtain the segmentations based on our previous projects. So the idea is that we want to develop a method that can generate the 3D co-illustration and reconstruct the vessels based on these data that's easy to obtain and are already existing. So we break this task down into two stages. The first one is that we want to co-register the 2D QCA images so that we have a coarse 3D model by using freeform deformation, which Marc has already mentioned earlier. And later on, once we have the coarse model, we want to co-register it with IVUS boundaries, the looming boundaries obtained on the IVUS frames as cross sections, and so that we can improve the looming resolution in our 3D model and also enable precise plaque visualization in the models, which obviously is our end game, our end aim in the cardiology analysis. So we start from a template-based approach. First of all, our data is multimodal. We have the original angiography images, a pair of them, and then the experts they do their annotation of the vessel boundary. So this is a kind of segmentation mask which we can use for segmentation and also for 3D alignment. And then we have, in this section of vessel, we have the ground truth 3D model that's generated by the commercial software. Then what we do is that we start by building a template of the vessel, and then we try to deform this vessel so that this template so that it can fit in the best way with our two angiography images. The way that we obtain the vessel is very intuitive. We basically collect the ground truths and then we put them together. We align them in the center point, and then we take the mean of the data set, basically. After we calculate the average center line and the average radius, we obtain a template, which is basically a tube in the 3D space. Now, taking this template, we try to fit it with our 2D angiography. Because we have two views, it's possible to obtain a coarsely registered 3D model. So our approach is that we design this unit structure. We use the encoder for two different purposes. So the features extracted from the encoding will be used for segmentation as a normal unit workflow, and at the same time will be used for the deformation of the template. So the segmentation will give us two masks for the two angiography, and the features will go into our freeform deformation process and predict the measures of the 3D model. This is a project as is in this very young stage, and we are still working on it, but I can show only some very early results. So as we can see, here is the original image, and this is the ground truth mask of segmentation, and we can obtain pretty good segmentation of the vessel. But here we can observe a clear challenge. The ground truth annotation that we obtain is only a small section of the vessel, but then the prediction of segmentation is for the whole vessel and even some side branches. So how do we pick up exactly the section in the predicted segmentation so that we can truthfully verify its correctness, and also use this for our for generating the 3D model for this particular section of vessel. This is one of the challenges we're trying to resolve at this moment. And there are a few steps to come once we have a good deformed 3D template. We need to also develop the same, train the same models, train the same networks for other types of vessel. Actually, in the examples I was showing is only about one type of vessel that we are interested in. There are a few other types of vessels. We also need to train different models for them. And we also need to expand the method to tackle side branches, because side branches sometimes are also very relevant clinically. And then after that, we mentioned earlier that we want to use IVUS, segmentation boundaries in IVUS to improve the looming resolution. So we will superimpose the IVUS looming boundaries with our 3D model and achieve a better, higher resolution 3D reconstruction of the vessels. And also, this will enable us to visualize the plaques naturally. Okay, so this is another example, and I'm sure you have seen many similar projects, but we have been focusing on several mainstreams in our group, and in all cases, we want to ensure that the projects, the aims are driven by true clinical demand. Obviously, sometimes the collaboration is fundamental across the disciplines, and this poses challenges, but also provide us with various opportunities. And here's my contact details if anyone has more questions or you want to discuss with me. And if you want to see more details of the work in my group, you're welcome to browse my Google Scholar profile. And that's all for my talk.
Thank you very much, Qianni. Thank you. For the interest of time, I think we'll just leave 2 minutes for a quick question. If there's anything from the audience here, and or if you want, please, if you're online, please type in your question in the chat. Maybe we'll be able to answer that toward the end of the day. I'll just have a very quick question, because you mentioned about the echo data. And you mentioned sometimes when you actually have the prediction, the cardiologists actually agree with the prediction you provide instead between themselves. And I'm just wondering, because when you actually carry out the machine learning test, for example, you do need to have the ground truth.
Yes.
For most of the things, I suppose. What happens if you don't have the ground truth, or the cardiologist, for example, in this case, they kind of not totally agree with you, but slightly disagree. Mm-hmm. What do you do in those situations if you don't really have the ground truth?
If we, it is very common that we don't always have the ground truth. So most of the methods I've been discussing about are following a fully supervised approach, meaning that we have the ground truth for training, and then we will use the ground truth for evaluation. But in many cases, we only have partially annotated data. For instance, a small amount of annotated data and a bigger amount of data which don't come with the ground truth, but you still want to use them for training. Then we have to use semi-supervised approaches. And also the bigger challenge is to sometimes to go even beyond this, to do the training without knowing any of the ground truth. So that's what we call the unsupervised approaches. Unsupervised approaches is relatively difficult nowadays, but there are many revenues that we are exploring in the semi-supervised domain.
Great, okay, thank you. Maybe we will take a 10-minute short break, so we're 5 minutes late. So everybody will come back at 4 o'clock, and next Professor Emanuele Trucco is going to look at how do we do the automatic retinal image analysis using the Vampire software. So we'll have a 10-minute short break, so everybody please come back in front of your computer in 10 minutes. Great. Thanks for everybody. Now hopefully you all have your coffee and little biscuit now, and now we have our final speaker, Professor Emanuele Trucco, and he's the NRP Chair of Computational Vision in Computing. School of Science and Engineering at the University of Dundee. He's also an honorary clinical researcher of NHS Taisai and a Zhang professor at Chinese Academy of Sciences. He received his MSc and PhD degrees in electronic engineering from the University of Genova, Italy. And here I'm not going to tell you which year, although he did tell me that.
People can imagine.
He has near 40 years of experience in computer vision and medical image data analysis, and he published more than 250 referred papers and also 2 textbooks. He served on the organizing a different program and committee of the major international and UK conferences. Emanuele has created and leads the vampire vessel assessment and measurement platform for images of retina, an international research initiative led by the University of Dundee and also Edinburgh. Vampire software has been used in the UK and also international retinal biomarker studies on cardiovascular risk, stroke, dementia, diabetic, and also complication, cognitive performance, neurodegenerative diseases, and also genetics. Emanuele is an AI advisor to the working group of the British Association of Dermatologists in charge of designing a national database suitable for AI tools. So today, Professor Trucco will talk about the automatic retinal image analysis in the AI era, the Vampire project.
Well, thank you very much. That was long. Good evening. This is the last talk, so I suppose I should be concise. I'll do my best. I want to talk to you about a large part of what we do in the CVIP group, that's with no fantasy computer vision image processing at the University of Dundee. So I'm the geographical outlier apparently here. Vampire is what I'll concentrate on in this talk, but as hinted that in the environment, I'll try to describe there's a number of other activities and organs being targeted. And first of all, however, before I say anything else, thank you very much for inviting me for this. It's very, very nice to see people, as you said before, in person. Okay, so the first challenge to move the slides forward. Very, very briefly, I think it is fair to start by telling you something about what is Vampire. And then I have carved 3 main things to discuss, hopefully not just a monologue about most of what we do, not all, but most of what we do revolves around the idea of biomarkers and the eye as a source of a biomarker. I'll try to briefly throw a number of impressionistic maybe messages about various projects we have. We are an interdisciplinary environment, but the group I lead, co-lead actually with my colleague Tom McKillivray in Edinburgh, is a computer science image analysis and data analysis group. So from that point of view, I think it is fair to try to present what works, but also what does not work and should work, and hopefully will work in the future, which leads us nicely to point 4. Where do we go from here? And feel free to stop me with the permission of the chair. Of course, if there are burning questions. Okay, so let me start with some context. Vampire is, I think, it's first and foremost a wonderful acronym. You have to agree. It's a real acronym, and there's been several sessions in various conferences where people say, "Hey, now we had a vampire talk." Okay, but apart from that, there are basically 3 things we try to do and pompously call the mission. So research, training, and translation. Research, essentially, we develop software, and we develop clinically motivated software, and it all revolves around the eye in vampire. We try to train, we're very interested in the concept of interdisciplinarity that we were discussing this morning. I'm particularly interested in the concept of effective interdisciplinarity. So clearly you don't want computer scientists to become doctors or vice versa. So there must be a sweet spot somewhere where you pitch your training so that at the end of the day, collaborative work actually works. But it's not easy to find. And then ultimately, you know, whatever we do must percolate down into healthcare somehow, be that through companies, through spin-off, through large companies we work with, Toshiba, whatever it is. And these are the three things. Okay. Right. So very, very briefly, I'll just pull this up completely. Ecosystem is a word we heard today already. I think it's a good description. Our ecosystem, which I must be totally honest, is much smaller than yours, Marc, but it is an ecosystem in the sense that it contains all the various pieces which we believe are necessary to accomplish the mission. So the four areas are there. There's some. Our bit is medical imaging data analysis, so that is there. But then this is tightly coupled, must be tightly coupled with medical research, because our research is mostly, as I said, I repeat for last time, I promise, but it focuses on computational issues. So it must be tightly integrated with clinical research as such, which immediately, and we heard something already today, it brings up the colossal universe and the colossally complicated universe of collecting data for real. And if we're talking deep learning, you know, AI in vast quantities, treating them, cleaning them, putting them somewhere in environments which are safe, which respect whatever rules, governance, and at the same time allow people like me and most people in this room to develop code. And these things do not grow on trees in real hospitals. Okay, and finally, there is an intersection and a strong presence of companies, of industry. As I said, in various incarnations, from the large ones to the medium-sized ones to one spin-off. We are one that we're generating as I speak, essentially. Okay, so let me take you. So that is as a crash introduction to who we are, and the whole thing is driven by the University of Dundee and Edinburgh in Scotland. Okay, instead this colorful illustration, which is due to my friend and colleague Alex Qianni in the School of Medicine of Dundee, gives you the I would say all the coordinates you need to put in place the various bits and pieces of work that I'll tell you about. There are 3 points to keep in mind. Okay, there's this triangle. One is the retina. That image there is a fundus camera image, but we work with a number of instruments which are deployed in clinical practice to look into the retina. Mostly human, but sometimes also animals, of course. The other part is the genome. So you can, retinome is a fancy name, but in practice, you can interpret the retina as one of the pieces of the phenotypes, a source of phenotypic information, essentially. Then the genome, and I'll say something about that as well. And then there's all the clinical phenome. There's a lot of O's in this slide. So all the information in practice you can source apart from genomic about a patient. And, you know, these are images, but you can think in terms of, and you should think, and we should think in terms of health records and information about the patients. So this triangle is basically captures the 3 main points of data that we try to integrate and to do what? The main question there are several detailed questions, but the main question that I invite you to keep in mind is what can the retina tell us about health? Okay, where I keep the word deliberately vague. Health will mean risk of various problems which are not specifically eye problems, like systemic problems, diseases like diabetes, vascular dementia, other form of dementia, and of course diabetes complications. The obvious one is diabetic retinopathy because we're talking retina. Okay, so what can the retina tell us, if anything, about human health risk, and if anything, how do we find out? And eventually, if we found out something, how can we put it in healthcare for real? Okay, so and this is where the some of the details begin. We work with a number of data sets, some of which will pop up during the rest of the talk, but I want to mention one in particular, which is Godard's. This is a program that is an example of the really good organization, and I say this because I have no part of it, so I take no credit, but the really good organization of healthcare from an electronic point of view in Scotland. They got their act together about 20 years ago, and they introduced a Chi number throughout the country. So a Chi number is essentially a unique identifier for a patient, but throughout the country. And they started collecting data. So we are not exactly yet, fast forward 20 years, we are not exactly completely in a situation where you can go to any GPs in the country and all your data come out, but we are very close to a situation in which the Federated Safe Agents of Scotland, with centre in Edinburgh, are now accessing practically all the radiographic data in Scotland, making them available for research. Something similar is happening for the field I'm more familiar with, like images of the eye in optometry, not for clinical ophthalmology. But optometry is a big business, and there's a project called SCOON, or Scone, south of the border, run by colleagues of mine at the University of Edinburgh, who is collecting the number of images. There is 1 million of images from optometry chains, essentially, which will be eventually used for research. Godard's concentrates briefly on diabetic patients. It was started about 15 years ago. That's a paper that describes, a recent paper which describes the cohort. It is strongly longitudinal. These are clinical data. This is not a study that synchronizes acquisition of clean data. These are clinical data, dirty data. All the patients, not the controls, unfortunately, are fully had a fully profiled genome. So more than 8,600 people, essentially, plus all the clinically prescribed drugs, of course, patient characteristics, patient information. All of them have practically all of them have retinal scans, which are part of the national diabetic retinopathy screening program. Every diabetic person is invited with different frequency, but say maximum twice a year, to have a scan to monitor the risk of the insurgence of, in the worst case, the progression of diabetic retinopathy. So this is a fantastic data set that we use a lot in our research. An example, and here I start to plunge into example of projects. So an example of a project which involves Modat and a network of partners in India, which has lasted for the last 4 years, is Inspired. That was Inspired was an acronym, not as good as Vampire. This was a project funded by NIHR. It was about £7 million, and the whole target was personalized medicine for diabetes in Scotland and in India. And it was an element of trying to understand differences and similarities, ultimately for therapeutic purposes, all revolving around the paradigm of personalized medicine. So it impacted genomics, it impacted phenotypes, retinal phenotypes, it impacted aspects of what I was saying before. How do you source the data? Where do you put the data? What should a safe haven look like? And so on. One interesting, for information, one interesting element of this program was the TREND sub-project in which our colleagues in India here or set up a van, an instrumented van, which was a wandering clinic, and went into the southern Indian bush to collect data, information, retinal images, and so on, blood samples from consented, of course, patients. So it was quite an interesting source of information for us, and of retinal images, which were analyzed with our software, of course, to do what? Well, once you have we should come back to this, but once you have a suitably organized set of linked data, meaning in our case, retinal images plus all other complementary information about the patient, then you can begin to look into, for instance, from the point of view of biomarkers for systemic problems, a classic, which is cardiovascular problems. You know this, but I should stress that the eye is the only part of the body in practice where there is a natural hole. There are other holes, but this is the only one through which, relatively cheaply, you can photograph, observe, depending on the instrument, a rich part of the microvasculature. Nowhere else this is possible. When I say cheap, in Scotland, the cost of the NHS of an image like this is, we can talk about details, but say £20. Okay, compare with the cost we trust of an MRI, we will go in the region of 500 or something like that. Okay, so if the more we manage to mine from images like that, the better, clearly. So this is an example of a study which appeared recently, the results in diabetes care. So using good arts and using, this is pretty much standard statistical, clinical statistical techniques, we showed that there seems to be, actually subject to replication and the usual things that quite rightly doctors want to do before declaring, yes, this is happening. It seems the retina can tell you something about the risk of major adverse cardiovascular events or MACE. I should add that good arts is a rather aged population, in the sense that the average age is 60 years, although there are patients much younger, like 20, 30, but the bulk is around 60 to 65. So one can discuss replications are necessary and so on. So this encouraged us a lot with, in this case, pretty much classic feature selection techniques. We also identified some specific features of the retinal vasculature. We will talk, there is a tale of two paradigms here, and we'll talk about that in a moment, but for the moment, I would like to anticipate that a study like this is based on what I think we could call a rather classic way of proceeding in statistics, certainly medical statistics, in terms of you have a dictionary of things to measure, and then you build models, whatever your algorithm, logistic regression, whatever you want, and then you say, okay, if I use this set of variables and I adjust for that set of variables, I get this. If I change the set of variables, I get that, blah, blah, blah. And you build different models. So this was built in that way, using some morphological measures of the vasculature, and I'll tell you about this briefly in a moment. Okay, I don't want to show you all the numbers in particular, but just look at the titles, okay? So we looked at this also using bootstrap and again logistic regression, regularized logistic regression, because we were interested in seeing is this real? Let's change the method to the same data set, and interestingly, results are very similar in the sense that yes, the retina tells you something. We got a different ranking of features, but we were comforted by the fact that some of the results is what you expect, like age, top, because the main unavoidable risk of bad things is age. That makes a lot of sense, particularly in an aging population. But then sensible things like the diastolic blood pressure, BMI, and so on. Okay, I'll go very far. So far, pretty much standard conventional statistics. We did this for a number of other things. So we asked questions like, of the same data set, okay? We asked questions like, perhaps can the retina predict specific parameters? Okay, not just events, not just death, not just risk of dementia, but specific parameters, continuous variables like blood pressure itself, glycated hemoglobin, things which are, I speak as though I knew what I'm talking about, things which are important for I understand, for diabetes. And again, something comes out, pending replications, which again is happening in other projects, which I'll try to describe quickly. Okay, I'll skip this one. One interesting thing that we were very happy to find, but again, always remember, the mantra is pending replications and so on and so forth. And if you remember the triangle I was showing before, we did a little study. This was done with a deep learning system. The question was, can we try to understand if we take three sources of information about a potential risk, which is a cardiovascular risk, okay? And the source of information are the retina, the scores that the GP uses. If you go to a GP and they find you're like me, you're hypertense, they have a standard system which is approved by the Royal College, and they ask you 5 or 6 questions, and they come up with a score, which is you got 75%, not in my case, much 5% risk of something bad happening to your cardiovascular system in the next 5 years, something like that. 5 questions, okay? And that's the second source of information, and the third is the genome, retina genome scores. Okay? And we looked at the associations in this diabetic population, the associations between these various sources. So does the retina add to anything? And we found, interestingly, that it doesn't add very much to the score, interestingly. But it seems to be rather adding a lot to the genetic risk. Of course, we should go, this has been published, but we should go into the obvious question is, what is the genetic risk? How many genes do you take into account? And in this case, very briefly, the genetic risk, it would be a perfectly sensible question. The genetic risk was defined with a small set of genes which are considered from evidence from GWAS studies, those which are mostly implicated with genes loci, which are mostly implicated with cardiovascular problems. So this is interesting because the retina seems to add something to other information. And if it adds something to genetic risk and in a sense can cheaply replace other sources of information, that's an interesting, begins to be interesting for clinical practice. The genomics expert that in our ecosystem ran actually a GWAS study that, again, interestingly, on a small population, because 8,000 people, if you do a GWAS, are not, you want the millions, but we didn't have the millions. But the random GWAS study, which very interestingly identified some loci in the genome, which seems to be simultaneously associated with or implicated with cardiovascular problems or bad things which may happen, and retinal features, like for instance, in this case, retinal venular tortuosity, so how squiggly the vessels are. Again, super interesting, being replicated in at least 2 other cohorts. I'm getting there. Okay, there's a number of things. There's a number of super interesting questions that, of course, you can ask once you get into the paradigm and you arm yourself with some pieces of software. Again, this is an example of predicting age. Does the retina predict age? This is being done, of course. Okay, so we were interested. It's not new. This was done a few years ago for retinas here in London, in Moorfields, and we just were interested in replicating the results on our set, and we did. So it seems that the retina, for reasons which are not entirely clear, I mean, we can imagine something. So my friends, the doctors, can imagine something, but predicts the age, chronological age, with a pretty good approximation. I mean, that MAE, the mean absolute error, is over the whole population. So, I should. But if you look at the table, this is divided by, if you look at the table briefly, that's a lot of numbers. This is divided by decades of age. Okay, and so of course the relative error is larger where there are fewer patients, and as I said before, the bulk of the patients are around 60, 65. Okay, that's pretty good. And it turns out, I don't have a slide here, but this is hot from the press. It turns out from another piece of work we're doing now, still with deep learning, that the biological age of your vascular system, which is what you predict looking at the retina, okay, because you're looking at the blood vessels, okay, so that gives you, if you're estimating age, that gives you an estimate of the vascular system via the proxy of the retina. The difference between that and your chronological age is actually a pretty good predictor of the risk of cardiovascular insults, which is better than just the straight estimate of age you get from the retina. Which, again, this is being published at the moment. I'll skip a couple of things. One big question here is why? So, and from our point of view, we are not equipped as computer scientists to answer this question in terms of pathophysiological pathways. But we can apply methods which are well known to, certainly from previous talks, trying to identify regions of the images which, from the point of view of the deep learning system, are the most important in terms of the task. So if the task is predicting age, for instance, we found, again, I'm skipping a number of details here, but we found that the optic disc seems to be the mainly responsible region in this kind of images for both male and female. But if we look at the prediction of gender, which can also be predicted, surprisingly enough, with a certain pretty good approximation, it changes for males and females. And again, we put these results to our clinical friends who were scratching their head. Anyway, so I spoke of replications, and briefly I want to mention that, for instance, we have a collaboration with a group in Canada at McMaster's University who have access to a large-ish 50,000 cohort of people on which they are running they have run, unfortunately, done our software. In particular, they were interested in one particular feature, morphological feature of the retinal vasculature, which is the fractal estimate of the fractal dimension. So if you consider, if you segment out the vessels and you consider that as a pattern, then you can estimate the fractal dimension, and that no doctor understands. Actually, there's an irony in this. Seem to be a pretty good, associates well to interesting things. So because if God exists, he's a humorist, I think, or she is a humorist. I do not know. Or it. So we're talking about 53,000 images here. Again, they have genomic profiles of the participants. So it's a good replication. They're not diabetics. So it's a good replication in a cohort with similar information, but there's a slightly different profile, not being diabetics than ours. And again, they've done an analysis based on using our software, which this is another chapter, of course, but I want to mention it, that does a screening of images by quality. So there are inclusion criteria which are clinical, and there are inclusion criteria which are computational, meaning an image must have certain textural, if you like, characteristics, contrast, blah. It must be processable in terms of extracting a sufficient part of the vasculature with sufficient clarity, uniformity, and so on, to be declared usable for computing parameters and doing the studies. This study is, again, of type 1, meaning, sorry, type 1 doesn't mean anything. It's of the type of, I have a dictionary of features that I extract from the retina, but I decide what features. There is no neural network discovering features here. In our case, there are 150 features for each retina, which are computed. I give these for 50,000 patients to my friends, the Canadian. They turn their cranks and they get some results. And again, I will not take you through the results, but through the tables in detail. But if you look just briefly at what comes out on the left, so what they've looked at on the left, you will see that there's, these are all parameters which play a role for a number of bad things which may happen, diabetes in particular, mostly cardiovascular things, but not only. So if you look at the bottom, you have things like cataract, for instance. You have things like, kidney disease may be related, of course, to diabetes as a complication and so on. So the highlighted phrase there is that there seems to be something really interesting being number crunched in this moment about, for instance, cataract hypertension. We know that retina tells you a lot about hypertension, of course, but work in progress, papers in progress. The other application, I don't think I have a slide here, but the other application, the other cohort in which this is being replicated at the moment is actually unavoidably UK Biobank, that has a subset of the UK Biobank patients have been imaged for retina, so there's about 50,000 people in the whole cohort. The images are not quality of the images of retinal images UK Biobank are not fantastic, but this is a separate chapter. So there's a lot to reject, but there's a separate chapter. Okay, I'll go quickly. This is actually the UK Biobank replication of the study on the fractal dimension and genes. This is led by Miguel Bernabeu at the University of the Ashram Institute of the University of Edinburgh. Ilenia was at the time a PhD student, and you can see at the bottom, actually, you can see if I move this guy here, but I cannot. Yes, I can. Anna Villaplana, now revealed, she's now taking care of completing the study as a paper submitted to some variety of the Nature group, which I don't remember. However, Nature medicine. The curves, once again, indicate that there seems to be some stratification possible using the retina in terms of, in this case, one specific parameter of the retina, which is this fractal dimensions, somewhat a measure of complexity. One of the most difficult things I'm trying to do in this moment, explain to doctors, but convince doctors not to say enormities about what the fractal dimension is, but end of the footnote. Okay, now nothing happens anymore. Yes. Okay, very, very quickly, from my point of view, from our point of view of computer scientists, this work, which has been going on for the last vampire for the last 20 years nearly, but particularly the recent 6, 7, 8 years have revealed a number of really interesting challenges. And when we started about 20 years ago, you can imagine that all the work was about computational stuff. We had no algorithm. We spent a long time developing algorithms and working with doctors. Do you think we should do this? Do you think we should do that? What should we do? What should we measure? And eventually we got to a stage where the algorithms there were a sufficient amount of algorithms, a sufficiently decent state that could be distributed, not only to our friends or immediate collaborator, but to the world. And now there is a network, a pretty extensive network of collaborators using our software around the world. But this work has revealed, I've mentioned the lights, but there are shadows in the sense that places where we should really shine a torch. For instance, we have these two paradigms at the moment, which I mentioned. One is handcrafted dictionary of features. These come from doctors. Fantastic. They know what they're talking about. Not always. Limitation. Maybe there are other things you should be looking at into the eye and reveal, biomarkers that the doctors haven't thought of. AI discovery. But then, of course, as we all know, it becomes a problem, a challenge to open the network and ask the question, what is the representation? You can get a representation out, but then get a doctor to understand the representation is a challenge. Okay, so that's a pretty important thing. I'm just picking here because I'm aware of time. How to mine together images and spreadsheets. Again, there's a lot of good work around, but I'm not aware of the ultimate solution. Meaning, if I really take the images and every other piece of data we have about patients, just to get to the point of developing software which uses both together, it's quite a road. Okay. Data cleaning versus AI is another thing which I have to say I learned working with doctors. My friend Alex Doney, who's a specialist of stroke, who works with us a lot, has convinced me that I was convinced that the really clever bit was developing algorithms. I'm now convinced that the really clever bit is organizing the data. And this is a bit sensational, but it's not far from the truth. I'll skip the last thing because I want to get to the last couple of slides. So very briefly, this part is just a very, very quick injection of information about what Vampire, now as a piece of software, not as an initiative, blah, 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 does. Very briefly, so as I said, we use different modalities, various instruments, images coming from different instruments. But here I present mostly what happens with fundus camera images, which is probably the most popular with OCT now, but a way of looking into the retina. So for an image like that, our software determines establishes a system of coordinates just with the optic disc, the white part in the middle, the macula, which is the darkish part on the right. These are coordinates we haven't invented. They come from ophthalmology. Why do these zones, these donuts exist? Because the ophthalmology think that it is interesting to divide the retina. You can do this incidentally, centered on the optic disc, like if you're interested in glaucoma, these kind of things, or centered on the macula, with typically diabetes screening, diabetes retinopathy screening images are centered on the macula. Okay. So this is done practically automatically, and then we've seen this at least, this is the third time we see a UNET, but that is an important piece of weaponry, I would say, computational weaponry to do segmentation, as we have seen in the excellent work presented before. Segmentation means simultaneously finding the optic disc, finding the macula. Now, I haven't managed to persuade my array to give me percentage errors, but when it says 100 pixels, doesn't mean anything. Clearly, if I don't tell you that the image has between 3,000 and 4,000 pixels in one dimension and about 2,500 in the other. 100 pixels seems a lot. Okay. Anyway, one thing is segmenting automatically the position of these landmarks, and the other is, of course, segmenting vessels, which means two things: segmenting vessels, thank you very much, and then classifying vessels in an arterial and venual veins network. Again, not exactly easy, frustrating thing. If you look at the literature, you find a number of papers saying, we've done it. Okay, and then you look at the experiments, and I mean, not to be cheeky to my colleagues, but there's a lot of papers. We've done it, and then you look at the data, and there are data sets which are either public with 50 images. There are some classic and retinal image analysis, or they are private and you cannot replicate. So it's my impression. It's kind of solved, but not in general, particularly because of challenges I will mention. I will skip this one. Okay. So what we, and now I conclude, what we want to do, in particular, our task at the moment, is to move from a situation sketched in this drawing, okay, where you give me input images, and I have a semi-automatic system, because I think I may say that serenely, that the three probably best known, most used, not best known, most used retinal image analysis of this kind systems around in the literature, which are Siva from Singapore, Ivan from Wisconsin, and immodestly, I should say, Vampire from us, all started as semi-automatic, meaning batch of processing, operator correcting, and the optic distance is not right, the Nuclei is right, correct, right? Vessels, touch up, spreadsheet with measurements. Okay, we want to go. The speed of processing is there. That doesn't give you more than 300 images per operator per week. That's ridiculous if you have UK Biobank, or now we are working with some colleagues here in Moorfields. They have run our automatic software for the fractal dimension on 1 million images, 300 images per week. Clearly, you don't do anything. Okay, so we want to move to this scenario in which, of course, we are moving. We have a prototype of automatic Vampire, plus uncertainty. I draw your attention to the bottom of the slide. This is absolutely important, and leads me to the last two slides, which is a selection of what should happen next. I immodestly think not just for us as a group, but as a field. We talk to and we try not to work in just within ourselves. We talk to a number of people around the world. So this is our distillate of what we think are the important thing to do, and there is a good overlap with what we heard before. First of all, one classic problem, briefly, is that if I get images from Dundee, the characteristics of these images, even with the instrument, is the same, or they will not be the same as images I get from another hospital. Okay, and then, of course, obviously, if we change, obviously, it should not be obvious, but it happens. If you change the instruments, still a fundus camera. So that is a big problem. It's a problem of generalization, well known. I think we heard this, and I agree entirely. Quantify uncertainty in the measures. If you are in the dictionary-based paradigm in which you measure specific things and produce a spreadsheet of numbers, I think it's very sensible. It doesn't happen at the moment to produce also uncertainty measures. Okay, and then the clinical statistician does whatever he or she wants. The next thing, identify representing key information in interpretable format, of course, refers to, if you do AI, explainable AI, which is a buzzword these days, but also a real problem. And data variability connects, of course, to generalization. Last slide. If the ultimate goal, and this is what I believe we are here to do, if the ultimate goal is translation of systems into improving healthcare, as Marc described very, very well, in our world where we are at the moment, meaning retina and biomarkers, there are three keywords which are the focus. One is explainability, as I tried to describe before. One is uncertainty, and the other is generalizability. Think of different centers, different instruments, different acquisition protocols. Okay. The fully automatic measurements is what, of course, with uncertainty is what we are working on at the moment. And I leave you with one thought captured by this slogan, artificial intelligence needs dictionaries. Remember, two paradigms, dictionary of features, discovery of features. So one thing that we started working on at the moment is a kind of marriage of the two things in which you try to use an AI discovery system. So your problem is a classification on outcome. You have a population of patients, you want to stratify them, okay? And you stratify them by an outcome, like MACE event within 5 years of baseline measurements, okay? Then you mine the network and you extract features, and then you take those features and you develop a specific system to measure those features, because the neural network does not give you measurements. The neural network gives you a representation. We think that there is something, certainly for the retinal biomarker, in that direction, and this is one of the places where we're trying to go. That said, I hope I haven't spoken for too long. Thank you very much, and these are a subset of the people who work in the group. Thank you very much.
Thank you very much. And, any questions from the audience?
I can ask one to get started. So the last point you were making, actually, so interpretability and sorry, I'm just going to. When speaking about interpretability, you were mentioning that we could create dictionaries, so extracting feature from a learned network or a model, and then use that as biomarker. But so I do understand the need when we've got trials and when we want to be able to contrast. But if a network is able to tell you with high accuracy, I mean,
I know where you're going.
A or B.
What's the need?
Why do you need the clinician to get in the loop there and to potentially have to understand how things are actually occurring?
Because, and I tell you, what I understand is the answer, Marc, because the clinician is in the loop. Because ultimately, we don't do that. We do that to publish in TMI. But ultimately, we want this to go to a clinician. The clinician is not happy, in my experience. They are not happy they will not believe something, our clinicians, they will not believe something they cannot explain. And explaining for them is understanding what is happening in the eye, in our case, that may be responsible for the answer. That is the answer.
But you've got that as a population level. So you can do epidemiologic study and look at population, yes, and understand the disease process. But
yes,
if you want to do something that's patient specific, you might not need to go into so much detail there. I'm trying to argue something I don't agree myself with. So, but I'm just not a big fan of explainability at the expense of decreased performances in a way. And that's,
I agree.
And we can't have both of them. So a lot of the cases we are losing by gaining on the other side. And that's the point I'm trying to go to drift to very slowly here. Right.
So this is very interesting to hear for me, because I wouldn't have thought that. I thought the two things could coexist in the sense that, in my perhaps naive view, you develop something maximizing performance, for instance, of stratification of patients on a target problem. And then you try to understand what's going on. But you're suggesting that you should modify the system at the expenses of performance in order to make it explainable.
Well, if you look at effectively what a neural network is, if we simplify it, it's a very high order weighted function. So that means that we need effectively to go to a very high order, which has a very complex model, and somehow we need to project it to very low features. So within this process, it's very likely that some of it is going to be lost. And even if we look at what's happening when we've got saliency map, or you were showing some breadcrumb there, so I think it was, but so highlighting some area of the image is not what people are expecting from an explainability standpoint. So I'm just having difficulty saying that we are going to alter the performances so that someone could understand something, but still, I mean, I'm struggling with this.
But don't you think that it's very interesting? Don't you think that the problem is not the way should not be simplifying and but finding how to transform whatever is the representation that converges in the network into something interpretable? I think I understand what you mean. When you say we have very high dimensional thing in the network and we have to, but the word I would use is maybe projecting, maybe interpreting, but not necessarily simplifying. Wouldn't you agree with that?
No, I agree. But let's take this here as an example. It's like you do a projection, you've got to your 2D space, you've got your eigenvectors that are representative, but you've thrown away the variabilities that went from high dimensionality to your low representation. I mean, you can't realistically, except if everything is aligned, you can't go to your, I don't know, like 70 dimension to your 1 dimension without any loss.
But okay, I understand.
But so all I'm saying is that it's for the current network. So maybe if we want to go toward explainability, we need to work. It's not necessarily one or the other, and we need to modify the systems that we are potentially using so that this could be explained. But it's just, sorry, I'm rambling a lot actually. I'm struggling with what we actually mean by explainability.
Okay, for that I have an answer, which is I see it like that. Again, I insist I may be oversimplifying. Okay, on the one hand, you have whatever representation is elicited by the network at convergence. On the other hand, and this is to me the concept of explainability, is the sort of concept that clinicians understand in a pathophysiological pathway. So, for instance, there are these processes. If I look at images of the retina of the patients, I know that, for instance, the morphology of the vessel, simple example, the morphology of the arteries will be altered if the patients are pretense. This is a super simple example. But of course, when you look at the weights, whatever the filters in a network, there's no concept of necessarily, certainly not by pretension, of directly, explicitly of morphological, or tortuosity or things like that. You have to, this is the translation process that, to me, selfishly, is at the center of explainability. Wouldn't you agree?
Yeah, but I don't think that we should then use a tool like a unit and then do some projection to get it. We should embed a priori knowledge within the model, and that's where we can make a difference, as opposed to blindly use a model like most of us are doing, as opposed to bring some of the priori information that we've got about the pathology and put that within the body, and then we can potentially link stats. And that's what we've been doing for a long time. I mean, we've had machine learning, then we went to Bayesian, then we are coming back to machine learning. So people are hoping that we might buy Bayesian, unlikely, but we might merge both of them.
Be careful about that.
I just want to say one thing, which is, I think more or less these are the last few lines in this slide. And when I say AI meets dictionaries, I mean something very similar to what you just said, if I understand you correctly. So,
thanks.
Thank you.
Thank you.
I can add to that only the interpretability is a little bit different. I agree with explainability in AI. I mean, for me, graduated as a clinician and go to the computer science world. I mean, I'm interested in how something can be explained, can be absorbed visually rather than have to blindly accept something that I cannot understand. But I think in the current state, how the explainability in AI is misused. I mean, the pathway of cause and effect has been reversed. So we use explainability to gain some trust from the user.
From the user meaning the clinician.
Yes.
Yes.
I think it should be the other way around. So if the clinician have some trust in the model, then it's likely that if the model is trustworthy, then what is shown on the 7C map or the GradCam are more likely to be right. On the other hand, I think if the ultimate goal is to gain trust, then I think that problem can be simpler to be solved. Like put the model into an RCT, compare the model do some prediction for prognosis model, something like that, or diagnosis model, compared to the actual diagnosis of some expert, and then we can, RCT has fully controlled environment, and then it has been accepted.
Mm-hmm.
And if the model managed to beat the group of clinicians, the standard of care, then the model gains some trust, and that is when the explainability of the model can be used to give some hint for future research, like some latent feature that we haven't never known.
Mm-hmm. So I would actually call on the other speakers as well to comment on this point, because it's not just for what I do. It's a general point. I would agree with the first part of what you said, which is, if I understand correctly, the clinicians see some maps, like for instance the one I've shown. They see that they mean something, they can understand, they can see some processes, and then they develop trust. And okay, the problem, the challenge there is that the kind of things I've shown are actually a very simple thing. It doesn't work always. You shouldn't think of this as the representation in a network. That is one way of looking at what parts of the images seem important for the network. Okay, but if you talk in terms of what representation is extracted by a network, this is where the problem is. I cannot show them to a clinician and say, what do you think? Because these are, at the moment, these are filters, these are numbers. And it's the challenge, in my view, is mapping that to things that you and your colleagues can understand. I don't know what Qianni and Marc think.
But if the model shows some, I'm working in the brain and arm for. And sometimes the model look at something in the frontal lobe, but the hot spot focus in the frontal lobe, but overlap in the skull. Then what can I do? Because what can I interpret?
Sure.
I mean, that's on, because that's if I believe it, then I think that is right.
Mm-hmm.
So if I already have trust, then I think what the model is looking at the right thing. And vice versa.
I agree. Sorry, I don't want to insist. But my point is, it is not always possible to give you an image saying, "Oh, look."
Yeah.
Okay.
So I think the cause and effect order, of explainability has been misunderstood. We have more trust than we believe in the explanation of the model, rather than what we are aiming for is to do the explanation to prove themselves.
We should also mention there's a huge debate if you get out of strictly technical paper and look at common papers, on AI in healthcare. There's a huge and hot debate, and from what I see, and there are people who are full of trust, and there are people who point out that. Oh my God, they're certainly not there. That there are contradictory results. at the moment, it seems to me it's a very open, what you call cluster seems to me a very open debate.
Yeah, I mean, strong lack of proper validation, like
Correct.
we've done in the trials.
Correct.
Well, thank you, everybody, because we do have people online, so I think we could continue our discussion here. But I do want to thank all three speakers today. Provides a really fantastic talk for us, and I really learned a lot. And we talk about the recent development. So maybe just the last 1 minute for each one of yours, our speaker here. One of my question is very short. What do you want to see or next in the development of medical image analysis? So maybe, Emanuele, you could
Me first?
Yeah, your wish list.
I would like to see real translation. I would like to see, I do not know in how many years, I would really like to see effective systems which improve healthcare using the kind of technologies that we develop. I'm not sure we're not there yet. There may be pockets.
Qianni, any wish list that you think for the next?
I think it's very similar to Emanuele's suggestion. We were discussing earlier that we developed loads of algorithms, train many models, and we claim that they are either specific to problems, specific to tasks, or they are more generalizable in some cases, but we hardly put them into practice, in the clinical practice. And there is procedural challenges for something to be acceptable by the medical teams, but also there are barriers, for instance, in the evaluation, in the validation of the softwares, and also the robustness, the generalizability. So I think providing the generic software platforms which enables the models to work together and to access data in a federated approach is something that can move us a bit forward in that direction. But still, we're very far from what we want to achieve, and yeah, long way to go.
Final.
Yeah, speaking last, you kind of took my wish list possibly already. So I'm just going to add a few things. So we are fortunate enough to work at the intersection of multidisciplinary. So where we've got, I mean, even a lot of different specialties, clinical specialty. We've got a lot of different engineering fields. We've got a lot of commercial opportunities with large companies, medium, small companies. And really adding to what you've said, so that we can close this translational gap, it's really important that we manage to somehow change the models, that we've got competition between university on one side, company on the other side, and really trying to have frameworks so that we can all work together and really foster the translation through collaboration of the different teams working on the problem.
Great. Thank you very much. And thank you all for coming here today. And also thanks people stay online with us. And have a good evening.
Thank you. You too.